Hi, everyone. I'm Helene from the foundation. Hi, Angela.
Hi, Helene.
How's it going?
Hi, Sylvia. I think we got you over.
All right.
Awesome. Okay, we're going to hang out. We'll sit tight for about another 10 minutes before it's time to get started, and roll right at 7:30 Eastern.
Okay. So do I need to stay on video, or how does this work?
You can. I'll do an introduction, and you can be on video for that, or you can do it just by audio. Either way.
Well, I will definitely be on video, I guess, if you're introducing me, but I guess after you introduce me,
I would go, we'll both turn all of our audio and video off after that.
Yeah, because it seems like we want the focal point to be what's already been done. Okay.
All right, I'm gonna mute us back out. Hello, everyone. We are going to get started here in just a second with Bright Smiles, our presentation for this evening from Dr. Sylvia Frazier-Bowers. And as we get started, I just want to introduce myself and some other folks who are on with us tonight. My name is Angela Christ. I'm the director of the Loeys-Dietz Syndrome Foundation and the director of marketing for the Marfan Foundation. And I also want to introduce you to Helene Baruch, who will be hanging out with us tonight, sharing some resources in the chat, answering questions, and helping, not answering session questions, but any other questions you might have, and just sort of helping us out in the session, especially in the chat. Hi, Colleen. Thanks for being here.
Hey, anytime.
Feel free to answer any other questions too. Just kidding.
No other questions to me, only to Sylvia.
We also want to say welcome to week 2 of the International E3 Summit, where we are educating, empowering, and enriching our community. This is brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS movement. And this is also brought to you by our partners in Europe at VESCERN. We thank you, every single one of you who's on tonight or viewing at a later time, for making this summit truly historic. We are just beyond excited for how this has gone. This is by far the Marfan Foundation's largest event, largest undertaking ever. We have more than 2,700 registrants from more than 70 countries. So welcome from across the world. And not only do you come from all over, but all of you as participants represent several different conditions. We've got folks, obviously a large percentage from Marfan Syndrome, but also representing many from Loeys-Dietz, VEDS, Stickler, and lots of those with just general aortic aneurysm and for interest. So a wide variety of participants across all kinds of places and conditions. We are also thrilled to have over 300 medical professionals who have been joining us and lending their expertise on these topics and also learning from one another. We could not say enough thanks to our sponsors, Brigham and Women's Hospital and American Communications Construction. So before we get into the heart of our presentation, I do want to note that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of the talks are those of the speakers and not necessarily those of the Marfan Foundation or VESCERN. If you hear differences of opinion from speakers and want further clarification, we invite you to please contact our help center at marfan.org/E3ask. And for questions of any kind that you submit there, of course, we want you to do that. Our goal is to make sure you have all of your questions answered as well as we can possibly help you get them answered. But we do ask for your patience, as I'm sure you can imagine the volume is pretty high right now, which is an exciting thing because we know that just means we're getting more and more good information into the hands of the people who need it. Also, one last little bit of housekeeping before we get started here. Whether you are viewing this session from the Whova app or on a website, like on a laptop or other computer, below the screen, below the window where you're viewing this video, there should be a rate button or link, and we really would love for you to hit that button as you exit the session tonight, or whenever you watch it. You can we ask that you rate the session even if you watch this as a recording. The more feedback we get, the better it helps us shape future information and education opportunities to meet the needs of our community, which is, after all, why we're here. Following this presentation, there will be plenty of time for your questions, so please put them in the Q&A for the session wherever you're viewing, whether you're in the app or online. We will do our best to answer as many of those questions as we can And, we invite you to submit any questions you'd like, but probably want to refrain from sharing too many personal details, as this is broadcast across the whole community. And with that, I would like to invite Dr. Frazier-Bowers to come up. Let me switch my video off and switch you on so you can say hello to everyone. I'm going to unmute you. Okay.
Okay, good evening, everyone. I'm honored, as always, to be here. I've been working with the Marfan Foundation for over a decade now, and we have a presentation that, thanks to the support staff, is already recorded and ready to go, but I'm also looking forward to hearing from you at the conclusion of the recording for some Q&A. So, Angela, I don't have a lot to share at this moment, but welcome you to commence whenever you can.
Okay.
Shall I keep my video on or off?
We'll stop our video down for right now,
Okay.
and then I'll bring you back up when this is done.
All right, thank you.
All right, let me just make sure we're all set. Video.
Good evening, Marfan Foundation family, educators, professional advisory board, and leaders. I am Sylvia Frazier-Bowers. I'm a member of the professional advisory board, and have been very fortunate to be a part of the Marfan community through the board since 2006. I've learned a lot from each and every one of those of you who come to these meetings every year. And I'm hoping to share things that I've both collected from rather anecdotal information and those that I've collected from evidence-based research. So primarily, I'm going to talk about the Marfan syndrome. However, there are some related disorders, as we all know from coming to the annual meeting, the annual conference, that are also covered. There's less information on related disorders, but there at least will be a mention of those today. And the major goals for today are to really just understand what are the dental features. Many of you have yourselves as indicators of what those dental features are, but we're going to talk about it more from the standpoint of what has been documented. And then what exactly what are the implications of the dental features, and how would we manage that in a patient with particularly Marfan syndrome? And then what are the resources that someone might seek to use in order to understand better? I know that everyone every year has a wealth of information on what the Marfan syndrome is, so I'm not going to spend a lot of time on that, but I do want to share this slide just to kind of put it in context that this is still considered rather rare, and it is obviously very genetic. But what's important today is that we understand the whole so we can understand the part that is the orofacial region. And the whole, in this case, would be the musculoskeletal system. Individuals with the Marfan syndrome have very hallmark musculoskeletal or typical presentations, but we're concerned today mostly with the face. And those features that have been documented include thin, narrow face, high arch palate, and down slanted or down turned eyes. So we're going to focus on this relative to what has been noted in the Ghent nosology, but then add to what we may know just from other studies. We also know relative to dentistry that a concern is the joint hypermobility. And the joint hypermobility is a concern because we all have a temporal mandibular joint. That is the articulation of our jaw with our skull. And many people know what the temporal mandibular joint is if they have ever had pain in that area. Because of joint hypermobility, this is an area that may be problematic for patients. We also know that there are cardiovascular involvements, and obviously this is one of the main characteristics of a person affected with the Marfan syndrome. But relative to the dental profession or oral health, we would be concerned about those who have certain aspects of cardiovascular problems because of that risk as a result for endocarditis. Mitral valve prolapse is, at least historically, one of those problems. The challenge with the Marfan syndrome and frankly, any of the connective tissue disorders is that the many faces of the disorder vary greatly. And when we're trying to deal with the variation that exists in the general population anyway, and then variation within the disorder, we actually have a harder time finding out what are the things that are absolutely associated with Marfan syndrome and the dental oral facial region, and what are the things that are just part of the normal population. And then when we look at the dental profession and dentistry, and we think about other connective tissue disorders such as Loeys-Dietz, it then becomes even yet another level of distinction to understand what is the difference between Marfan syndrome and Loeys-Dietz in a dental perspective, from a dental perspective, excuse me. A low-hanging fruit concept is that Loeys-Dietz is very often associated with bifid uvula and is sometimes also associated with a cleft palate. This is not associated with individuals with the Marfan syndrome. So that's one lower hanging fruit relative to what makes these two things different. And so, again, it can be very tricky trying to figure out which dental feature is because of this connective tissue disorder or is because of the dental characteristics that exist in your family. As I mentioned before, many of these characteristics are common in the general population. And if you don't have some of the characteristics that we think are associated with, for instance, Marfan syndrome or Loeys-Dietz, doesn't mean that you don't have that. And when we think about how the dental characteristics play a role relative to other major criteria, it is that they become, in some cases, not only additive, but synergistic. So the dental characteristic alone may not warrant much attention, but in combination with other major criteria, sort of strengthens the argument. So if you visit the Marfan website, the Marfan Foundation website, you can, from that standpoint, look at, for instance, teeth and the Marfan syndrome. And this is readily available just from going to the website. It does not have, say, the rigor that I'm going to include in this session today. It does not necessarily go through many of the details of facial features, malocclusion, or antibiotic prophylaxis. So let's take a look at that now. What we really like to focus on, and what I find year after year is critical to focus on, is those frequently asked dental questions. Because if people keep asking the questions, it certainly suggests that these are questions that at least anecdotally, are questions that are bothering individuals in the Marfan Syndrome and related disorders cohort. So when we think of frequently asked questions, we really have two categories. We have questions that patients often have, and we have questions that providers have. And that provider could be a dental provider. It could also be a medical provider. But those are the two categories. And let's just deal with the patient questions. Because of the connective tissue disorder, will I or my child need braces? Does Marfan syndrome always cause a narrow upper jaw? And will I or my child need an expander? And what type of expander should I use? Will I or my child need jaw surgery? Does Marfan syndrome cause weak enamel? This is a question I get literally every year. Do I absolutely need antibiotics prior to dental treatment? And is there a specific dental treatment that is unsafe for Marfan syndrome? Those are some of the questions that are commonly asked. I will not necessarily cover all of those in the following slides, but hopefully some of them. But the doctor, researcher, dentist questions are, how can we better diagnose using what we already know? And do we expect that those individuals who have Marfan syndrome will respond in some type of way to our treatment that is either really good or not really good? And do we need to have a very specific custom protocol for individuals with Marfan syndrome or related disorders? So first and foremost, we should at least understand and agree to what the craniofacial features of Marfan syndrome are, using methods that are vetted to quantitate the shape and position of the jaws. Before we do that, let's just think about the teeth. The most common feature that we see in individuals with Marfan syndrome is just overcrowded teeth. The upper jaw or the maxilla is often narrow, and if it's narrow, it means that there's not enough arch circumference that's going to accommodate the teeth. A manifestation of this is a posterior crossbite. It means that because that upper jaw is narrow, instead of the upper teeth articulating or intersecting with the lower teeth so that they are outside of them, they will be inside. And we can look at that and see what that looks like. Well, here's an example of a very narrow vaulted palate, and the vaulting refers to the deepness or the depth of the palate, and narrow is what would resemble a more of a V shape versus a broad U shape. So again, we're going to look at the crossbite, but does a vaulted palate almost always mean that you're going to have a dental crossbite? Not necessarily, but certainly having a narrow palate usually means you're going to have a crossbite. And why do we even need to fix a crossbite? Well, the crossbite most certainly usually reveals that there's an underlying jaw problem, typically with the size. And if we address that while the face and jaws are still growing, it actually is advantageous because it will prevent having instead the jaw shifting to one side, or the patient functioning in a way that causes them to have lopsided jaw growth, or wearing down of the outer layer of the tooth called enamel, of the material called enamel, excuse me. So here's what a crossbite looks like, as I described earlier, where the upper jaw is resting on the inside of the lower jaw, which is the opposite of what we want. And this is a picture of a young child, and you can probably perceive that these are young child teeth. And often what we use to correct that at the appropriate stage or age, which is sometime before all of the permanent teeth come in, while they're still growing is a rapid palatal expander, sometimes called a Hyrax. And this is something that you use the little hole to turn it every day. And as you turn it, the screw opens and it puts pressure through this metal framework to push the teeth to a better position. So that's one problem. The other problem really speaks, as I mentioned earlier, to characteristics of the face that we hope we can correlate with Marfan syndrome to help diagnose. TMJ disorder also is something that when we do our exam, we can determine if that exists in the patient, and that may help to paint the picture of Marfan syndrome. We already know that certain people are more genetically disposed to TMJ problems. And the fact that the Marfan syndrome is associated with a genetic problem that causes connective tissue issues, which include the connective tissue of the joint, really further confirms the genetic link. And so what does that mean for dentistry? There are a couple things this means. One is that treatment has to be done with great care so that we don't exacerbate the jaw problems, making them worse. But the flip side of that is that sometimes when treatment is done, it will help lessen the manifestation of the TMJ problems. What is another characteristic we see? Periodontal disease is something that occurs in the general population, and to date, there's not enough data or studies that say individuals with Marfan syndrome have a greater predilection to periodontal disease. I also have people asking, well, is my enamel more weak? Again, there's not enough evidence-based data that suggests that, mostly anecdotal. However, as we discussed earlier, if you have a crossbite and you're biting on the inside of your upper teeth, there is the possibility that you may wear your teeth down more, but not necessarily that you have a genetically defined gene product such as enamel that is less normal or that is weak. We cannot make that conclusion yet. But regardless of what your genetic makeup is, there's a lot you can do to really help mitigate the side effects of anything, whether it's coming from having the Marfan syndrome or whether it's coming from the same thing that exists in all patients across the population, which is just plaque. Plaque is something that constantly builds up around and on the teeth. And if you remove it really effectively, you're going to place yourself in a position where you won't have the likelihood of gum disease. And you can use different types of toothpaste that are formulated with different types of fluoride. And those are more effective at removing plaque. Stannous fluoride is one of those, and it was something that was used quite a bit in the past. And people are going back to that, using stannous fluoride because it is 3 times more effective at removing plaque. It actually is more effective than monofluorophosphate, which is typically what's in toothpaste. And this is actually heightened if you have professional cleaning. So I'm not really making a pitch for Parodontax or Gum Detoxify, but those are both sort of good options to think about if you want to address an issue with plaque and gingivitis. The other reason for really focusing for the Marfan patient on your mouth is because the mouth is a mirror to your whole body. If you don't keep your mouth clean, it actually increases the likelihood that you have other other issues with systemic health or with systemic diseases. So one of the things I have to tell people, especially as it relates to infective endocarditis, is that what that refers to is the fact that certain bacteria can or pathogens can get into your bloodstream, and those with weakened hearts will be at a greater risk for that having an untoward effect. So what I tell people is that one of the things, even aside from dental treatment, that you can do to keep this at bay is just keep your teeth clean. That's another reason to keep your teeth clean, because a lot of people worry that a dental procedure is going to cause them to have the potential of infective endocarditis. But in fact, brushing your teeth, if you haven't brushed them in a while and you have plaque and bacteria really built up, that actually could give you the same risk of infective endocarditis as having a procedure. So keeping your teeth clean absolutely all the time is of paramount importance. And so we took some time to really think about as many things as we could as it related to how orthodontics and malocclusion shows up in individuals with Marfan. And I always say the goal is to search for the truth. And that is the quest of the academician. So we set out to look at craniofacial characteristics, and we looked at some other things as well. But primarily, I want to talk about the craniofacial characteristics as an addition to the literature of the Marfan syndrome, which the Marfan syndrome literature in dentistry, orthodontics, and oral health is actually very thin. So we wanted to add to that. And we already know that there are certain features that are present in individuals with the Marfan syndrome. Oftentimes, we can see it in the eyes, we can see it in the shape of the head from front to back, we can see it in the narrowness of the face and the way that the jaw is positioned. So we set out to look at patients with the Marfan syndrome at 3 different conferences. And we also evaluated some patients with Loeys-Dietz and Ehlers-Danlos. So we did measurements in person. We also took photographs, and we looked clinically at everyone's oral condition, and we asked some questions. In summary, I'm not going to look at everything, but in summary, we did use a system defined by a researcher named Farkas, and we did some typical measurements, and we found that 9 of the 12 measurements were normal, but the ones that weren't normal, i.e. along some average trending value, were biocular width, the width of the face, and the width of the nose. Those were the things that were not that fell outside of the range for people with the Marfan syndrome. We also found that 35% of our population had some orthodontic treatment, but this may be based on the age that we looked at of the study. The people who we looked at, some of them were very young, so they may not have had treatment yet. And the key problem in all of the patients we looked at, or individuals who participated, we looked at, was the high arch palate and dental crowding. So some things we learned is that there were certain features, such as proband, meaning a person who first showed up for the study, and then if someone in their family showed up, we also looked at them. But the person who was first diagnosed in any given family tend to be diagnosed later in life than someone who had a family member that was already affected. We also noted that facial width, biocular width, and like I said, width of the nose were things that fell outside of the range of what was considered typical. And having your eyes slanted downward or down turned at the palpable fissure and a small jaw were frequently observed. And I won't talk about the aortic finding. So the previous studies also found that having the downturned eye was present, and they also found malar hypoplasia was also present. So what are the challenges to actually trying to create characteristic rubrics for individuals with Marfan syndrome relative to dental and facial characteristics? One is the challenge is that there's so much variability, as I mentioned early on, that it's hard to really get a good hold on what is caused because of the Marfan syndrome and what is caused because of some other trait in a family. And the other issue is even within the Marfan population, we found this, is that the phenotype evolves with age. So you actually are likely to have a different presentation as you age. So what do we need to know now? And what is it that many of you probably are still interested in knowing? Many people want to know, when you get braces or when you just have regular treatment, what is it that you should expect in terms of needing antibiotic prophylaxis? The antibiotic prophylaxis guidelines have continued to be more conservative because we do not want to reach a time where those antibiotics we use to help prevent severe infection are no longer useful because they've been overused. So now what we typically do is determine from that individual patient's medical history and their current cardiac condition whether they would need antibiotic prophylaxis. But the majority of procedures, especially that such as having braces, really don't require that you have any type of antibiotic prophylaxis. Traditional braces are like having the little things glued onto your teeth, and we call them brackets. And these brackets and wires are still very much in use today, and they don't typically create a problem with someone with Marfan syndrome, both in their presence and in what their action is, which is to gently move the teeth. I think I want to skip before I go to that. Clear aligners is another type of way to move the teeth. And these are thin plastic trays, and they now make this, surprisingly, so that you can use it as a child. So they now have aligners that can be used for children. So this is another very good way that we can allow patients to keep their teeth clean while they're undergoing treatment. And this might be a really good alternative for the Marfan patient. And one of the main questions I get all the time is, what about the use of implants? There's not a lot of data on implant success in patients with connective tissue disorders, and often when I see things published, specifically relative to implants or treatment, it's a case study. It's like one case or it's a few cases. But in general, the guiding principle is that overall patient health is the best way to determine what type of treatment plan you can have, whether it can be a little more aggressive, such as implants, or whether that would be contraindicated. But overall, implants have a high rate of success. So if you're thinking about the advances made in dentistry, implants are among that area where advances continue to be made. It's very reliable. If you are healthy and not at high risk for endocarditis, then you are likely to do very well with having an implant. What about sleep apnea? A lot of patients with the Marfan syndrome and in particular any connective tissue disorder talk about the morbidity or risk of having a problem sleeping and breathing rather. And that's a very valid concern. And there are appliances that can be made to help Sometimes that will be done in combination with orthodontics and jaw surgery, but sometimes you can just have a sleep apnea appliance made. And you do need to see a sleep medicine specialist. So you need to see your MD first, and they work with the dental professionals who are also trained in this area. This is not necessarily all dentists or orthodontists that you go to. It is a very super or subspecialized area. And without any further ado, I am done. Sort of an abrupt ending here, but I'm hoping that this stimulates questions that people have and maybe gives me some more information that I can take back and give more facts for later. Thank you. Good evening.
Almost got a quick little restart there. I'm going to bring you back up, Doctor, and we will go through a few questions. There are lots of questions in the session's Q&A, but I believe many of these were answered in your presentation. So I don't want to go too much back over these questions, but we'll start with ones that I'm pretty sure were not already answered. And a lot of them had to do with the different ages of people who are living with these different conditions. So this top ranked question, I suppose, was about dental and orthodontic interventions. Says they seem to be important for young people with Marfan syndrome, but what dental issues do adults with Marfan syndrome need to pay attention to as we age? So, I mean, I know you talked a lot about this. This is basically the crux of your presentation, but are there things that you would separate out as being specifically more important for people as they age versus young adults or younger people with Marfan?
Sure, I'm happy to take a stab at that. So the benefit of being young is that you are, and this is kind of general as it relates to life, you're sort of you're still malleable. There's still evolution for that person, and it's not that as we age we don't change any. In fact, we do change because we age, but relative to moving teeth and or bones, it becomes there become less options to do so with someone who is an adult. So that's one thing to be clear of, that if you did not take an opportunity as a growing child or a younger teenager to have treatment, any treatment you have subsequently will not allow you to take advantage of your growth potential. Now, what about what you need to just pay attention to just for your quality of life? The quality of life for us as we age is to make sure that we are mindful of everything that makes us healthy. That is our diet, the things we're eating, and how we're caring for ourselves or removing agents that may be of harm. And frankly, plaque is one of those things. So the better you are at removing plaque and minding your diet so that you don't have too many sugary foods that generate plaque, the better off you will be. And I know that sounds a little bit reductionist and minimal, but that's the reality, that as you age, the best thing you can do for yourself relative to any connective tissue disorder is to keep your hygiene tip top so that you don't introduce the agent of bacteria from your mouth that can get into your bloodstream and cause the problem.
Thanks, that's a great answer. I know it's probably, like you said, it probably feels a little oversimple, but it just comes down to the basics on that one, huh?
Yes.
Okay, next question. And there was a question about implants, but I think that was pretty much answered. Although within this question, now that I say this again, there was sort of a sub question about if adult teeth never developing is is like a thing for Marfan or LDS? Both were asked.
Good question. Oh my goodness. So I'm so excited because actually that's what my area of expertise was
There we
in my
go.
postdoc. My area of expertise was tooth agenesis. Agenesis, that is the absence of genesis or beginning or development. And I can say from all of the genetics that have been done and the genotype phenotype studies, that is those studies that are genetic but correlate with a specific phenotype, there is no knowledge that points to the fact that a person with a mutation in the fibrillin gene should also have a problem with their teeth. So, fibrillin is not known to encode for teeth. So with that being said, we have to realize that every single human has their genetic background that they have in addition to the fact that they may have a major disorder. So there may be, obviously, and there probably is, if that question was asked, people out there who actually have tooth agenesis completely unrelated to their Marfan, Loeys-Dietz, or any other connective tissue disorder. So at this point, none of the evidence-based studies have shown that those two are correlated, but the fact that they occur together is just the same likelihood that, you might have an allergy or asthma with Marfan syndrome. I mean, they're just two separate things that happen to have occurred together.
That is really interesting because there were several people who chimed in on that saying, yeah, this is a thing, but
yeah, there's absolutely no evidence. And I will say something to the no evidence. The issue with no evidence, and I've said this at other Marfan conferences, annual conferences, I've said, absence of evidence is not evidence of absence. So just because we do not yet have the evidence does not mean the thing is not a thing. It means that there is not enough of a significant cohort to prove it. And then if I would be remiss if I just said, oh yeah, 5 other people told me this, so it must be so. It's really not so until we either have a strict molecular study that proves it is so. And there are a lot of fine researchers in Marfan and other connective tissue disorders. And it just has not been found that this phenotype or characteristic of missing teeth or weak enamel is really associated with the genetic defect. It is in fact either a byproduct of the fact that they have Marfan, meaning something they do because they have Marfan caused it, or it is completely unrelated.
one extreme or the other.
Yes, and you just don't know unless you have enough of a cohort. And people on this call and people in general probably are aware that there are a lot of studies done on the cardiac effects and some other skeletal effects of Marfan, but and other connective tissue disorders, but not so much on dental. So, these individuals who have been coming to the conferences are aware that it takes quite a robust cohort to actually discover something new.
For sure. Okay, switching gears a little bit. This next top question is about TMJ or displaced discs in the jaw. The person who asked said, this is not from trauma, but is there a higher instance of these things with LDS patients? What kind of treatments are recommended if custom bite plates do not work, and would adjusting bite via braces be helpful or recommended?
Okay, that's a very good question. One thing that has been shown with evidence is that if you have Loeys-Dietz, Marfan, or if you have any connective tissue disorder, because the jaw joint is, and the entire disc and capsule that creates the mechanism is made up of connective tissue, you're likely going to have some untoward effects there. So that is evidence-based. If you do notice you have jaw issues, it is legitimate that came from the fact that you have a connective tissue disorder. The question is now, what are we going to do about it? It varies from person to person whether there is a significant enough jaw problem that maybe they should have disc replacement. That's actually a thing. Or whether just adjusting their the way their teeth relate to one another through braces would help. Unfortunately, I can't say it is an exact thing for every person. It depends on the diagnosis of the way their teeth relate to one another. But it is true that if you have a connective tissue disorder, that you will have a greater likelihood to have a jaw problem.
Okay. I'm gonna skip down just a second in the Q&A because there's another question toward the top here about jaw dislocations. It says, I'm having trouble with them. It is making dentist trips hard because opening it enough dislocates my jaw about half the time. Anything I can do to reduce the risk of jaw dislocations during the appointment?
So if you are someone who has a reduced opening, then you just have to respect the reduced opening. If the question is, how can I, trick the system, that is the system of your body's limits, and overcome it, the answer is no, you may not do that. You need to tell your dentist, and I've had patients who say, I can only open this much, and then that's what I got. That's what I'm working with. On an occasion that you are able to open more, certainly we would take advantage of it, but there is no way to kind of trick the system and be able to open a lot more. So you just have to respect it and work with it.
I like that answer. You can't trick the system that is your body. Oh,
Yes.
There's one we all need to learn just in so many ways.
Exactly.
Next question. I have exceptionally weak teeth. They break very easily. Is this common with Marfan? Is there something I can do about it?
And so, yeah, I'm glad, this was one of the questions in my FAQs. And, I hate to say it, we did do a study of individuals who were affected with Marfan. We had some with Ehlers-Danlos. I think we had some with Loeys-Dietz. But, our bottom line with having over 40 patients, which is not a lot, is that we could not isolate having quote unquote weak enamel in our study nor in any other study in the literature. But again, absence of evidence is not evidence of absence. Those people who are experiencing that are really experiencing it. The question is, does it correlate with any of these disorders, or is it just that person's is it that person's outcome because of their other genetics from their family, or because of their other behavior? So remember, one thing I said is that some people have these things called posterior crossbites. What we have begun to speculate is that if you have a posterior crossbite, depending on how your teeth are meeting each other, you might wear them down more. And that will contribute to weak enamel in the back teeth. But that would not account for the quote unquote weak enamel in the front teeth. So while there is some cause and effect, we would not inherently expect someone to have weak enamel just because they have Marfan or Loeys-Dietz. It has not been proven yet. So just put it that way. Whether it actually exists is another story, but we just have not found that in our study or any other study yet.
So I just want to make a couple of notes here as we are answering these questions, because you've said several times, Doctor, that we don't have a big enough cohort, we don't have enough research or enough data to really answer these questions definitively. And one of the ways that we're trying to work to build better cohorts of people with Marfan, whether there are dental issues or not, is through the Backpack Health and the International Registry that we have for Marfan and related conditions in there. I know we have a session coming up on that. I believe it's next week about Backpack Health. There's also a lot of information on the marfan.org website about it. So if you're interested in helping to advance research around this area, that would be a great place to start and help.
That is a very good point. I wonder, I know we can't have a show of hands, but I wonder how many people on this call are participating in Backpack. And, you know, would people be willing, and are they willing? I mean, I don't know. I know all about Backpack. I've been, because of being a member of the Professional Advisory Board, I've heard all about it. But I wonder, does Backpack have regular polls that go out? So
we're actually working on that. And part of the reason we need more people in is to better substantiate those polls. So, you know, but we might do a survey. We could do a survey in general with this particular, the whole E3 summit, asking people about their participation in that. And I will make a note of it. That's a good question.
Yeah, that would be awesome, because again, we understandably have a focus on cardiac health, because that is a feature of connective tissue disorders that is literally life-threatening. Some of the other features are more a matter of quality of life, and therefore they don't get as much of the large cohort studies. So, but that's something that I would be happy to help investigate, either through a survey, through Backpack as a mechanism, or whatever is possible.
Well, you know, we'll take you up on that just as soon as we're able.
Because it would be a wonderful service. Because
awesome.
If I had a nickel for every time I was asked that question over the years, I would definitely quit my day job.
So also we're going to post a little bit of information about Backpack in the chat in case you are unfamiliar, and it is an international registry where we are, it's sort of a win-win for patients and investigators. And I won't go into detail on it here because I want to get to a few more questions before we have to wrap up, but we'll post some more information on it. Also, if you subscribe to the Marfan Foundation's e-news, there was a survey that went out today. It was not around dental issues, but it was around Backpack Health and on pain and headaches. So that's like another area where we're trying to get a little bit more of a little bit more investigation going through polls and surveys related to people who are in Backpack. So, okay, enough of our pitch on that. Let's get back to dentistry. Let's see here. I kind of lost my place. Thoughts on Invisalign versus braces? I know you talked about orthodontia.
And so I will say Invisalign keeps coming up. They keep coming up. I mean, I was one of the first adopters of Invisalign. I was one of the first users in 2000. And that was literally now 20 years ago. Wow. And I had just finished my residency not too long ago. So that was at the beginning of my career. And at that time, you couldn't do people who had too many spaces. You couldn't do people who needed to have teeth extracted to help the treatment go. You couldn't do people that had a disproportioned upper and lower jaw relationship. But now Invisalign has improved so that you can do almost everything. You can even plan a surgical procedure, meaning moving the jaws around, by using Invisalign. It used to be that was not possible. And there's more. Not only is there Invisalign Teen, there is Invisalign Child. So there are actually multiple Invisalign options. And I will say the one benefit to Invisalign for someone who is affected with a connective tissue disorder is that it is removable. So that means that you can take them out and brush your teeth really well. Because remember, we don't want to have someone with a connective tissue disorder to not have their teeth brushed well. Because just as a dental procedure can cause infective endocarditis, so can just having teeth that are not brushed well with a lot of plaque and bacteria. So the short answer to the question is that if your orthodontist says that you are a candidate for Invisalign, it actually might be a benefit, as long as you're going to be dutiful and wear it as much as you need to. It actually may be a benefit to your overall health and mitigating risk of, for instance, endocarditis. So I would support that.
That's really good information, especially knowing that the technology, so to speak, on Invisalign has evolved in that way.
Yep.
Okay, several questions here. I'm gonna try and combine them again. Questions about gums, receding gums, recommended treatment for this. That one was specifically for someone with VEDS, and I saw another one, bleeding gums, treatments for bleeding gums, especially while on warfarin. I know those are two actually pretty different questions.
Oh,
Sorry, I lumped them together.
There is an association with Ehlers-Danlos and periodontal issues. I'm not saying it's necessarily VEDS, but there is an Ehlers-Danlos that has an association with periodontal issues, meaning the gums can recede, they can bleed, that the bone can recede. So that's real. When anyone has any of these disorders or issues, the best treatment is to manage well with your diet and your care. Unfortunately, there is no pill you're going to take to just make it all go away. There are some periodontists who will have certain antibiotic treatments, and sometimes they actually put them down into the pocket of where the problem is, but that's not a long-term fix. The long-term fix is just take extraordinarily good care of how you clean your teeth. But as far as the other questions, so I think you said bleeding gums.
Yeah.
And I'm sorry, say it again.
Warfarin.
So using anticoagulants, you just need to talk to your dental provider about what types of ways you can best manage your periodontal or dental health. I'm hoping in times when maybe you're not on that. I mean, I guess if the person is I don't know what the situation is, but if you can have a professional cleaning maybe when you're not on that particular medication, and then you can do a good job at maintaining, you can maintain in an excellent way regardless of if you're on that particular drug. And if you are doing an excellent job of removing plaque, you will not have bleeding gums, even if you're on warfarin. The issue is that if you have any semblance or minor presence of plaque, that can sort of catalyze the potential to have your gums bleed.
So, you know, a lot of questions, a lot of really good questions in here, and some of them very specific to individual cases. So I have one last question I'm gonna pose to you, and then I'm gonna re-encourage everyone to please do submit your questions, whether they were answered and whether you were asked, they were asked in here and we didn't get a chance to answer them, or you'd like further detail or follow-up. Please do submit those to marfan.org/E3ask. We will get back to you just as soon as we can. It is absolutely our highest priority to make sure you get the information you need to lead a wonderfully successful life. So we will help. We just may take a little bit extra time right now just because there are so many questions being submitted. One last question I want to ask, and I think you know, this is probably a question that any parent could ask, but wondering if maybe there's even a special angle given kids with Marfan or LDS or any other connective tissue condition might have a special sensitivity to, given the situations they might be experiencing within their teeth. But the question is, any tips on guiding children to feel comfortable and safe at the dentist? My 5-year-old LDS daughter has been terrified. She doesn't want anyone near her mouth. And we all know that this can be phases that kids go through, but it also could be, somehow related to what they're experiencing within their dental situation. So just
that's a really good question. I recommend that individuals that have individuals who are part of the Marfan or LDS or whatever community, that you identify specialists. So first and foremost, if you're a young child, you should be going to a pediatric dentist who's a specialist. If you have the ability to identify a specialist who's also affiliated with an academic health center, then it's even better, because what that means is that specialist has at their disposal other specialists who would help with the medical and other dental. And usually you will find that those individuals are highly trained to deal with apprehension, anxiety, etc. And there are lots of highly trained individuals who aren't in that setting, but the ones who are in that setting are usually highly trained. And the key to building that relationship where the child will eventually be comfortable is just that. It's building a relationship. So the first time that a child goes, that's probably not going to be the case. But if they can potentially, first of all, identify the right specialist and then build up and build a relationship, the likelihood is that it's not really that it's a phase. I think that can happen to anyone, regardless of their age. I think it's more of a reality based on whether a relationship has been cultivated or not. So just as you do with anything, you need to cultivate that relationship. And unlike when we are little kids and we go to elementary school or grade school, we have a teacher and then we switch, and every year we switch. Well, you do have an opportunity to build a relationship with your healthcare professionals because you don't have to switch every year. So I would just say do some word of mouth, asking your friends and family who they go to, who they're comfortable with, and then build a relationship with that person. It's not necessarily going to happen on the first visit. It might, but it probably will happen after visit number 3. So I would say stay the course.
That's a great answer. This has been just such a lovely session. Your overall information and your care for all of these questions has just been so nice and really so much great information. And thank you so much, Dr. Frazier-Bowers.
My pleasure.
This, like you and I talked about earlier when we spoke a week ago, it's not a topic we get to talk about quite as much. And I know just based on the number of questions we had, it's certainly something people are interested in.
Mm-hmm, mm-hmm. Well, so, you got me when you said we can do something with backpack. I'm ready. I'm serious. I'm not just saying that because I'm being recorded. I'm definitely ready.
Oh, well, I know we have other folks from the foundation on tonight who are listening to this, and I know they're writing it down too. Like, we got to get on it.
I'm ready.
We're on it.
All right. Well, thank you. And thank you for inviting me. I know that there are individuals I had some people reach out to me personally, and I actually had personal Zoom calls. So if there are people who really have that sort of, burning question and they feel like they just need a little more depth, I'm welcoming you, and I'm able to do that.
That is so generous. Really very kind of you. And also, I just want to throw out there again, whether people want to reach out to you, or we're always available. And through this time, we're taking those questions again at marfan.org/E3ask, whether it's about dental issues or anything else, mental health, physical health. We are here to answer those questions.
Yes, and yes, it is better if you go through the Marfan Foundation. The person who reached out to me did so literally through Weimer himself. So it wasn't like I randomly cultivated relationships. So
Okay,
yeah, please go through the Marfan Foundation, but I would be happy to set something up
great.
personal if that's needed.
Okay, very good. And as we're wrapping up here, for folks who have been on with us or who are watching this on the recording, please complete that session survey. Click rate this as you're leaving, and it takes less than a minute. It's super painless. We just really value your feedback and would love to hear your thoughts. Also, there are some wonderful exhibitors who are providing different resources or who have information that may be helpful to you. Please do go visit them in the virtual exhibit hall. And if you are not yet participating in the community via the discussion boards or the different comment threads, you are definitely missing out. There is some wonderful conversation and really cool connections that are being made across conditions, across continents, on all different kinds of topics, both connective tissue, condition related, and just life with people who get it, right? So please jump in and see what you can learn or connect to through the community. That's just so powerful with almost 3,000 people participating. It's just, what other opportunity do we have like this? And if you are a social media person and are sharing about your experience online, we would love for you to use the hashtag E3Summit20 to tag your thoughts or your photos with this session. We have had a few really cool posts come up that we've then reshared through our social media, and just love to see how you're experiencing this. Finally, if you want to see more educational and community programs like this summit, please, we would invite you to make a donation. Your support is absolutely what enables us to continue this life-saving work. The website is on this PowerPoint. You'll see there, marfan.org/donate. We'll be also posting it in the chat box if you want to follow that link. And you know, it's been a wonderful series of presentations to be able to offer for the low price of free. So if you feel like you want to be able to give back on this, we would welcome that, of course, anytime at marfan.org/donate. Thank you again to
Yes,
Dr.
Thank you for inviting me.
Sylvia.
Thanks. Have a wonderful evening, morning, whatever time it is in the world where you're viewing this, and we look forward to seeing you on another session very soon. Bye-bye.
Bye.